reported. Not only are they common, but they're very common. So this falls under disorders of the cornea. Keratitis involves some inflammations of the cornea, which are infectious in origin. There's also photokeratitis, which is a kind of similar process, but it involves involves ultraviolet exposure. Corneal abrasion is going to be what we talk about here, and then there's also some other less common disorders of the cornea involving dystrophies, primarily genetic, and keratotorus and keratoconus. So the cornea is here in relation to the rest of the eye, and it is consistent with the sclera. The cornea is clear, it's transparent, and that's important because we need to allow light to get through the anterior part of the eye, through the lens, and ultimately to the retina, where the image is processed and sent on through the optic nerve. So the cornea, being clear, is made up primarily of collagen. It doesn't have any arteries or veins. It gets its nutrients through the aqueous, and the anterior aqueous is directly posterior to the cornea. The cornea also has some refractive properties. I think it's about 46 diopters. Don't quote me on the exact number, but it's somewhere around there. And that's important for ultimately projecting the image onto the retina. And there's some disorders where the cornea is not shaped properly, and that can result in distorted images. As a matter of fact, LASIK surgery primarily alters the shape of the cornea to improve the focus of the image. So that's the surgery that you get to correct abnormally shaped lenses. You're not necessarily changing the shape of the lens, you're changing the shape of the cornea to compensate. So this is a cross-section of the cornea. Don't worry about the histology, but it's just good to know that there's different layers of the cornea, so we kind of have an idea of where these things are happening. So this is the outer side, outside of the eye. This is the inner side. This would be the anterior aqueous chamber here on the left. So starting from the outside, working our way in, we have the epithelium. This is stratified squamous epithelium. So these outer cells are flat like pancakes. You can see the flattened nuclei here, and then they become a little bit more columnar as you work your way inwards. Separating the epithelium from the stroma is a thin layer of basement membrane called Bowman's layer. And you have the stroma here, which is the largest layer that's in the middle. And then there's a sort of basement membrane for the endothelium that's called the Descemet's membrane. And then the endothelium is the innermost portion, and that's a squamous epithelium. Okay, so a corneal abrasion is a mechanical or chemical disruption of the corneal epithelium. So we're talking on the outside of the eye here. And this is the most common eye injury among children, and probably the most common eye injury in the general population as well.
My goodness.
Lesions heal very quickly. The epithelium has a very high turnover rate. It replaces itself generally within 24 hours. But the time to healing generally depends on how deeply the cornea was injured. So if it was just a couple layers, it'll heal faster than if it were several layers. Typical causes, you can imagine direct injury, so fingernails. If you're itching your eyes, mascara brushes. I don't have personal experience with that, obviously, but
hello.
That's where you take that applicator and
how are you?
Your eyelashes to thicken them up.
Welcome to my channel.
It's very imaginable that you can accidentally touch your eye that way. Branches.
And guys, guess what I'm doing?
And you run into a branch and it pokes you in the eye. That can cause an abrasion. Chemical injuries like mace. This is very common. The mace can harm the epithelium, and that will cause a larger abrasion. Flowing dust or debris. Extended use of contact lenses, really just contact lenses in general, because if you're placing a contact lens onto your eye, you're actually getting your finger onto your eye, and you might get your nail onto your eye. I used to wear contact lenses until I got LASIK surgery about 2 years ago, and believe me, I have extensive experience with having had corneal abrasions. not comfortable. And then there's also iatrogenic
And see
causes.
after shopping
A
and
lot of
pencil.
patients who are disabled on bed rest, who need help from nurses to keep themselves clean. The nurses may be washing their eyes and accidentally cause a corneal hemorrhage. The symptoms, typically the patient will present with eye irritation or even pain, but typically this is a sensation of having a foreign body in the eye, sort of a gritty, itchy feeling that you can't get the thing out of your eye. You can have photosensitivity, blurred vision is certainly possible, especially since if you have an injury, it will change the refractory property of the cornea in that particular spot. The patient generally will be able to relate to some kind of a trauma to the eye that preceded the pain, but you're usually going to have to milk that out of them. They won't just tell you because they might not know that rubbing their eye caused this, or putting their mascara on, they might have hit their eye. So you should definitely ask, have you rubbed your eyes? Have you used any mascara? Has anything gotten into your eyes? When did this come on? Were you doing anything at that point in time? And of course, it should be relatively recent because corneal abrasions tend to heal on their own within about 24 to 48 hours. So the physical exam will typically require a topical anesthetic. Patients with corneal abrasions, especially if they're severe, especially if it's a child, they won't want you to touch their eye. So topical anesthetic
Hello.
is useful, and that anesthetic will actually
Who's Remus?
really make a difference for the patient. And that's one of the ways you can tell that it's probably a corneal abrasion. You're just putting an anesthetic on the very outer portion of the eye, and it's only going to hit outer nerves. And if that really makes a difference, that
Hello,
helps you,
Guadalupe.
sort of narrow your diagnosis down, or at least point you in the body of the corneal abrasion. You may note some conjunctival erythema, and a lot of that is not due to the abrasion itself, but due to the fact that the patient has been rubbing or trying to wash the quote-unquote foreign body out. There should never be pain on eye movement. That's a sign of something else. If there's pain on eye movement, then there's something wrong with the extraocular muscles or with the
Muchas gracias, Guadalupe.
So that should never be present. Also, there
¿Te
should
gusta,
never be corneal haze. That's going to point you more towards a keratitis. This is just on the outside, so there shouldn't be anything inside the cornea. And the pupil should be normal, although sometimes there can be a reactive miosis, but in general it has normal reactivity. You should also inspect the cornea and lids for a foreign body. A lot of times foreign bodies will be darker, they may sit around the iris, so definitely inspect the cornea because there might indeed be a foreign body that's present rather than abrasion. And your differential, you're going to have, of course, other causes of red eye. There's not always significant red eye with corneal abrasion, but if there is, you need to narrow down, rule out the other causes of red eyes. Conjunctivitis, typically with conjunctivitis, you're going to have a discharge. And also with conjunctivitis, you should not have abnormal vision. You shouldn't have any blurred vision. Acute anterior uveitis typically has a poorly reactive myotic pupil. And acute angle closure glaucoma will not be a foreign body sensation or mild pain. This will be the worst pain the patient has ever had in their life, and they will have extremely blurry vision. Infectious keratitis is another possible cause, but in this case, typically the patient will have a corneal haze. You can, if you're worried about infectious keratitis, if there really is significant red eye, you can do a fluorescein test to look for an ulcer. But with infectious keratitis, there will be ulceration. Ultimately, we will do a fluorescein test to test for corneal abrasion. That's next. But we'll talk about how to differentiate that out. Photokeratitis, another possible cause of this itchiness, this uncomfortable eye. Typically with photokeratitis, there's been an exposure such as skiing or snowboarding, something outside where you weren't using lenses to protect your eyes from the
Hello, CR7.
And then a foreign body, of course, is also on our differential, and that's why we're inspecting the cornea. So here's the corneal abrasion. Apart from maybe a little bit of erythema, we don't see anything wrong with this eye. And that is what you would see in a corneal abrasion. It doesn't look like there's anything wrong. However, when we use fluorescein, we see that there is a problem here. So normally, when you use fluorescein, what you're doing is you're putting this dye onto the patient's eye, onto the cornea, and fluorescein will not attach to the epithelium. However, if the epithelium is denuded, then Bowman's layer is exposed, and the fluorescein will attach to that. And so this is all areas here where there was denuded epithelium. So this is very linear, so this could possibly be from a mascara applicator. It's another corneal abrasion. And these are a little bit bigger, but this is also a corneal abrasion according to the source where I have this from. This also looks very similar to an ulcer, and your differential is primarily, in that case, going to be how long has this been going on? Was there any preceding trauma? So for diagnosis, we're going to use fluorescein staining, which will demonstrate the abrasion either grossly or under a cobalt blue lamp or a Woods lamp. Sometimes you don't even need the lamp. This is I'm not sure if this is the same eye or not, but looks like the same eye. Here you can see the lesion is present without a lamp, but some of the smaller ones you may need the lamp to sort of amplify the fluorescein. Under the suspicion of ocular trauma or a routine foreign body, you should consider an ocular CT or an MRI if the object is non-metallic. Obviously, you don't want to get magnetic resonant imaging of anything if you suspect that there's something metallic in there. But this is why you look for a foreign body. If the foreign body looks very superficial, you can try to wash it out with some saline. If that's not successful, you can apply some anesthetic and try to get it out with a cotton tip applicator. Anything deeper than that, you need to send off to an ophthalmologist. For treatment, this is something that does not last very long. Corneal abrasion does not last longer than 48 hours in most cases. So primarily what we're concerned about is pain control. So typically we'll just give the patient PO pain meds, oxycodone, and acetaminophen is usually good enough. Some sources I've seen have actually said that you can use topical pain medication, but again, you run into the problem there of reducing or inhibiting the healing process. So I'm not so sure how good of an idea that is. Reassure the patient that this is not something that's going to last very long, should be gone within the next day, and they'll usually be okay with healing things. Prophylactic topical antibiotics are controversial to use routinely, but there are certain patients in which you would want to use prophylactic antibiotics, especially patients who wear contact lenses. The reason why is because they're at greater risk for keratitis. So, especially if the patient is a contact lens wearer, if they have a recent history of swimming where they can be exposed to acanthamoeba, you'll definitely want to give these patients topical antibiotics. But it's really at your discretion. The antibiotics that are typically used, we want to cover Pseudomonas. So, one of the newer generation fluoroquinolones can be used like rofloxacin or gentamicin, but make sure it covers Pseudomonas. And then patient education, of course, avoid contact.
Using just short lines
because we don't want to expose the patient to any
to detail the shit.
or fungus or Pseudomonas or acanthamoeba that's on the contact lens. And then use protective eyewear, especially if they got this occupational. The patient, if the pain does not go away within 48 to 72 hours, or if it gets significantly worse, they should return, and typically they'll be referred to ophthalmology. The topic here is going to be diabetic retinopathy, and this is a very, very, very important topic in ophthalmology in your clinical practice if you're working an outpatient clinic, or even if you're working with older adults as a hospitalist. The reason is because so many people have diabetes. 10% of Americans have diabetes, and I think that's a conservative estimate because a lot of people have diabetes and don't know. Furthermore, that number can only be expected to increase as our population gets fatter. People are going to be more and more likely to develop diabetes as they get older. So diabetic retinopathy is not fully understood as far as its pathophysiology goes. However, what we do know is that it's a pathologic breakdown of retinal small vasculature.
Pero Jonathan, ¿qué dices?
Due to persistent hyperglycemia.
¿Qué me estás diciendo, Jonathan? Que no entiendo bien. Explícame a ver.
And it also damages the basement membrane of the vessels. And so because of this, you damage and ultimately destroy the vessels, but not before causing fluid to move out of the vessels, proteins, lipids to move out of the vessels. So this is a breakdown of the retinal vasculature, and it's primarily encountered in patients with poorly controlled diabetes mellitus. But some people may have well-controlled diabetes and still develop retinopathy. But having controlled diabetes and making sure it is controlled will do you a lot of good in reducing your risk of progressing towards diabetic retinopathy. Okay, so this is the leading cause of new onset blindness in adults aged 20 to 65 years. It affects up to 80% of patients who have had diabetes.
¿Estás ahí, Jonathan?
Or more. Now, a lot of people have diabetic retinopathy and they don't know it, and they don't have symptoms, and they may not ever develop symptoms from it. So that 80% number is staggering, but it's not necessarily
Jonathan, ¿estás ahí?
Really have problems from diabetic retinopathy, but it is reflective of how many people could develop problems from diabetic retinopathy. It all comes down to how well you're controlling your diabetes most of the time. So remember that the leading cause of new onset blindness in the elderly, people 65 or older, would be macular degeneration. So in patients with type 2 diabetes, when they're diagnosed, 40% of patients will have some retinal changes, some vascular changes, some change on an ophthalmoscopic exam that's consistent with diabetic retinopathy, even though they don't have symptoms. 20% of patients who are newly diagnosed with type 2
Jonathan, ¿estás ahí?
actually do present with visual changes as their presenting symptom or one of their presenting symptoms of their diabetes. That said, all patients with a new diagnosis of type 2 diabetes mellitus should be referred to ophthalmology for a baseline evaluation. In patients with type 1 diabetes, because these are usually children, retinopathy will not present for at least 3 years after diagnosis, and typically these patients don't need to start getting observed by an ophthalmologist until they're in puberty. The best management for diabetic retinopathy is primary prevention, as I've alluded to, so controlling blood glucose level through a healthy diet, exercise, and anti-hyperglycemic medications, and insulin if necessary. So we classify diabetic retinopathy into non-proliferative and proliferative. Proliferative just means that you're growing abnormal new vessels. So non-proliferative diabetic retinopathy would actually make up the majority, because the majority of people who have diabetic retinopathy actually don't know it. And that would be the people who have background retinopathy. So this is where you show signs of diabetic retinopathy on ophthalmoscopic exam, notably microaneurysms, small hemorrhages, which can be dot blot hemorrhages or plain hemorrhages, and hard exudates, which actually comes from vessels that have been disrupted. So these patients will have mild changes on ophthalmoscopy, but they don't have any symptoms and they don't have any changes in vision, even though they have these changes on ophthalmoscopy. This doesn't require any immediate treatment, just the primary prevention of keeping glucose level normal, making sure that they exercise, all those things you can do to prevent progression into proliferative diabetic retinopathy. Now, on the other hand, you can have diabetic maculopathy, and that's different from diabetic retinopathy. Diabetic maculopathy is a manifestation of diabetic retinopathy, and this is where you have edema and exudates or hemorrhages that involve the macula.
Jonathan,
So,
estoy preguntando si
whereas
estás
with
ahí
background retinopathy, you had these changes
porque me dices una
on other
cosa
parts of the retina.
y ya no
If
estás.
these changes involve the macula, typically it's going to cause symptoms. And those symptoms are the same symptoms that you would have with any kind of macular problem. Blurring, decreased acuity, darkening, those scotomas that you see in your central vision, and visual distortion. So this would be a symptomatic form of non-proliferative diabetic retinopathy. This is diabetic maculopathy. Apart from using the ophthalmoscope, you can also do optical coherence tomography, and this will better visualize where the problem is and its severity. And maculopathy is the #1 cause of blindness in patients with diabetic retinopathy. So you can go blind with diabetic retinopathy, and you don't have to have the worst form, which is proliferative diabetic retinopathy. All you need is to have maculopathy, and if it doesn't get treated soon enough, and even if it does sometimes, you can have a permanent decline in your vision or total blindness. Now, the worst form is proliferative diabetic retinopathy, and this is the most advanced stage of diabetic retinopathy, and of course it's associated with a poorer outcome. It's characterized by neovascularization, which tends to be pretty obvious from the optic disc or major vessels, and because those vessels are fragile, you can get vitreous hemorrhaging, and you can also get tractional retinal detachment due to any of the fibrosed vessels that have been diseased, fibrosed. And that can be a tractional spot or retinal detachment. I'll show you a picture towards the end of the lecture. Vascular proliferation can also involve the anterior structures of the eye, notably the iris and the angle, and that can result in glaucoma because the vessels will block the angle, and that will raise the intraocular pressure, and that leads to something called neovascular glaucoma. That is a complication of diabetic retinopathy, but we're not going to talk about it here because that's a topic for another subject. We'll talk about glaucoma. Okay, so this, for the most part, is a normal retina. So you might see here are a few changes associated with diabetic retinopathy, but certainly nothing that would cause symptoms. So you might have a dot blot hemorrhage down here at about 6 o'clock. And also at about 6 o'clock, 5 o'clock, you've got some hard exudates. Okay. And just remember that the hard exudates are just kind of scar formation that are due to breakdown of the blood-retinal barrier, and what they are proteins and lipids, as well as proteins from the vessels. So they're just dead vessels. Okay, so you might see some here, and then perhaps some up here. Now this is a little bit more obvious. Here you've got your dot blot hemorrhages. Here you have some dot blot hemorrhages around here. This looks like it might be a burst thrombosed vessel. And there's some plain hemorrhages, and then you have your exudates, hard exudates here, these bright spots. Here's some very obvious hard exudates, not quite on the macula though. The macula is right here. This is zoomed in a little bit more than the other ones. The macula is right here, so the macula is not involved. Got some bleeding here and hard exudates, but nothing that's involving the macula. You don't have any neovascularization. Okay, so this would be an advanced feature of non-proliferative diabetic retinopathy. So this is called a venous loop or a venous bead, and when you see these, this is rather ominous, and it says essentially that the patient is at risk for developing a significant risk for going on into the neovascular form, the proliferative diabetic retinopathy. I'll show you some more pictures of these when we talk about proliferative. So again, here you see tortuosity. That's another bad sign. They're abnormal hearing vessels. So diabetic maculopathy is disease that affects the macula. So this often occurs with non-proliferative diabetic retinopathy, but it can also occur in the setting of proliferative diabetic retinopathy. So unlike background diabetic retinopathy, diabetic maculopathy is symptomatic, and it can be considered a more advanced form of non-proliferative diabetic retinopathy. But patients with diabetic maculopathy do not necessarily progress into proliferative diabetic retinopathy. The whole question is, what part of the retina is affected? You have one little part of your retina called the macula, and it's very important. And as long as the macula is not affected, for the most part, you're not going to have any symptoms. But once that macula is affected, you're going to start to show symptoms. And those symptoms include loss of visual acuity, scotoma like black spots in central vision, blurred vision, image distortion, especially relative to the other eye. What does this sound like? This sounds like macular degeneration. And all that means is that the macula is not functioning properly. So when you look into the patient's eyes, you will see signs consistent with diabetic retinopathy, especially since this is a patient that probably already has diabetes, or labs consistent with diabetes, and you'll see that the macula is affected. For diagnosis, an ophthalmoscopic exam is the first test, and that will show abnormalities. It'll show the hard exudates and the hemorrhages in the area of the macula. Then optical coherence tomography, as I mentioned, is more accurate, and that can show you the macular edema that's consistent with diabetic maculopathy. So here's diabetic maculopathy.
Hello.
Macula right here,
How are you?
and you see hard exudates.
Thank you for joining my channel.
Macula is affected. Unlike the previous pictures I've been showing you, the macula was not affected. Here's some more. And this is the optical coherence tomography. This is the macula that you're looking at right here. And this should be flat up against the layer deep to it. But you've got fluid collecting up beneath the macula, and that's what's causing the symptoms. This is macular edema. And pretty much always macular edema accompanies diabetic maculopathy, but it can be difficult to see macular edema just with your ophthalmoscope, unless you're a master ophthalmologist. So this is a good way to confirm your diagnosis. If you have a picture like this one that doesn't necessarily show a whole lot of abnormalities in the macula. Most ophthalmologists will do this test in patients that they suspect maculopathy. So the way this is treated is by laser photocoagulation. Sometimes they use intravitreal VEGF inhibitors, or they can use vitrectomy if there's consistent problems with bleeding. But diabetic maculopathy is primarily treated with laser photocoagulation. And as usual, primary prevention will continue to be important in these patients. Proliferative diabetic retinopathy is the most advanced stage of diabetic retinopathy. In this case, native vessels have endured damage to the point where new vessels are forming. And proliferative diabetic retinopathy is characterized by neovascularization, and that can occur anywhere from the optic disc to the major vessels and beyond. Hemorrhaging is very common. Microaneurysms, dot block hemorrhages, and vitreous hemorrhage can be present as well, or it may also be the presenting symptom in some cases. With continued vascular proliferation, new vessels can progress to the anterior structures. They can block the angle of the eye. That can lead to glaucoma. Dead vascular tissue can fibrose and can act as a source of traction, and that can lead to tractional retinal detachment. The symptoms of proliferative diabetic retinopathy can be blurred vision, and that can be either from vitreous hemorrhage or macular edema. Floaters, and that can be from if there's any kind of vitreous material or any blood or material in the vitreous, that can cause floaters. Difficulty with nighttime vision. Symptoms of complications can be present. So if you have retinal detachment, you can have photopsia, floaters, visual field deficits. If you've got neovascular glaucoma, then there's pain, photophobia, and you can see neovascularization of the iris, and then you can also see conjunctival injection of that. Like I said, we're not going to talk about these complications. We talked about retinal detachment, we talked about glaucoma pretty soon, where I'll address neovascular. But these are some of the complications that can come up. And with proliferative diabetic retinopathy, you can have symptoms of complication with presentation. So the way to diagnosis, of course, is through ophthalmoscopic examination. And typically, patients with diabetic retinopathy, we're doing an ophthalmoscopic examination on them every year, or the ophthalmologist is. And so we're charting their progression. And that ophthalmoscopic examination is necessary to establish the diagnosis, along with other tests like visual field tests and acuity exams. Another thing that can be done is ocular tonometry. If they show signs of glaucoma, that measures the intraocular pressure if glaucoma is a concern. The treatment for proliferative diabetic retinopathy is panretinal photocoagulation. And this tends to be the first line treatment. However, other things can be done, especially this new treatment came out within the last 10, 15 years at most, and that's intravitreal VEGF inhibitors. And what you're doing is you're injecting VEGF, which is a product that inhibits vascular epithelial growth factor, and by doing that, you will inhibit the growth of new vessels. And so this is an injection that's put into the vitreous. There's another, I'm trying to remember, I think it's triamcinolone, which is a steroid. That can also be used, but usually the intravitreal VEGF inhibitors are used if you're using medication. But panretinal photocoagulation, I would say, would be your answer on the USMLE if you get a question on this. So this is proliferative diabetic retinopathy. You can see here you've got what look like those loops here, and then here coming out from that, you've got neovascularization. And this is pretty close to the optic disc. And of course, you got bleeds, dot block hemorrhages. This is severe proliferation. Here's another one. So you can see there's a locus of proliferation, neovascularization here, neovascularization coming out of the optic disc. But the macula is spared here. So here's proliferative diabetic retinopathy with a vitreous hemorrhage. So this is a patient that may present with a gradual blurring of vision because they're looking through blood. Here's a fibrous band. This fibrous band is just dead tissue that can show up with diabetic retinopathy. And the problem with these fibrous bands is as you're turning your eyes, these can be points, traction points, where you can get retinal detachment. Retinal detachment is a whole other animal that's treated in a totally different way, but it's very problematic when you have diabetic retinopathy because the retina is already fragile. So you don't want this. This is diabetic retinopathy, but this is in a patient who has had photocoagulation performed, and that's what these little white spots are. They're just scars from the laser. Notice that they, of course, went around the macula because we photocoagulated the macula. Well, then we have no vision. So, it went around the macula here. That's why this area is not done. So further management, remember that patients with diabetes mellitus are at increased risk for other ocular problems besides just diabetic retinopathy. There's also an increased risk for cataract formation, as well as thrombosis to the retinal artery. All patients with diabetes should have blood pressure and lipids monitored. Remember that blood pressure increases your risk of clots and atherosclerosis. And atherosclerosis and clots will increase your risk of thrombosis to the retinal artery. And they should also have their lipids monitored for that reason too. And of course, any adult patient in general should have those things measured, but it takes on more importance in a patient with diabetes. A hemoglobin A1C is the best way to monitor patients' long-term compliance, long-term progress with their diabetic regimen. And we prefer to have these patients between 6 and 7%. Smoking reduces retinal oxygenation and may upregulate VEGF, so that would accelerate progression to or of the proliferative disease if they already have it. So stopping smoking is always a good idea, but particularly in patients who have diabetic retinopathy, we want them to stop smoking so they don't start making more VEGF and putting themselves in proliferative disease. Also, since we're talking about diabetic patients already, beware of prescribing the thiazolidine diones, TZDs. Why do we want to avoid these? Because they are associated with an increased risk of macular disease. So we would prefer to have the patient on a different kind of anti-hyperglycemic if we can. The thiazolidine diones are medications like rosiglitazone or Avandia or pioglitazone, which is Aptos. So remember that when you've got your patients with diabetic retinopathy. When do you refer to ophthalmology? Well, of course, any patient that needs a procedure done needs to be referred to ophthalmology. All new type 2 diabetics will be needed to be referred to ophthalmology for their initial examination, and then they'll be seen every year after that. All type 1 diabetic patients should be referred roughly 3 to 5 years after onset or around puberty. It depends on the age. So if they're adult patients, you can refer them 3 years after that. If they're little kids, like 3-year-olds, then around when they hit puberty, then they should go see an ophthalmologist for a baseline exam. And then, of course, all diabetics who have an acute change in vision, even if you don't see anything with the ophthalmoscope, a handheld ophthalmoscope is not a great way to make some of these more complex ophthalmologic diagnoses. So any diabetic with an acute change in vision should be sent straight off to ophthalmology. And of course, any diabetic with a sudden drop in acuity, we're concerned about the macula, those patients should be sent off to ophthalmology urgently as well. If you have any questions, please feel free to leave a comment below. Full person disorders that we've highlighted here. I want to do a quick overview of the anatomy, just to orient ourselves, talk about the pre-inflammatory disorders to focal inflammatory disorders. inflammatory disorder called blepharitis, which has many causes. And then some other eyelid conditions which are a little bit less tested on the USMLE: entropion, ectropion, trichiasis. Certainly, though, you will encounter these in clinical practice, especially if you work with a geriatric population. But I would say that these first three here, ecclesia, cordial, and blepharitis, are the most commonly tested on the USMLE out of all these things we're going to talk about. And then tumors, these are tumors that occur elsewhere on the body, especially the skin, but I just wanted to briefly talk about them because they move around the eye. So the external eye here, some obvious points: upper lid, lower lid, lateral canthus, kind of hard to see, this is the right eye here, this is the bridge right here, and then the medial canthus. So the lateral and medial canthus are just the ends of where the eyelids come together, lateral and medial side. And this little pink spot here is called the caruncle, the lacrimal caruncle, and that's where the tears come out. What you can't see here, or inside, is the lacrimal duct, which ultimately empties into the nose, and then the lacrimal gland, which is on the superior and medial aspect of the eye. Orbital septum is just a hole in the skull where the orbit sits. It's roughly, you have to palpate, but it's roughly this area here. Going a little deeper, got the orbital septum, as we just showed, the superior and inferior tarsal plates. The tarsal plates are what give the eyelid its characteristic structure, and this is just dense connective tissue. Then you have the medial and lateral palpebral ligaments, and this kind of holds the eyelid in place. And you've got a lacrimal sac, which ultimately brings you to that crown. You got three muscles here, all of which are innervated by the facial nerve. The orbicularis oculi muscle, which is traditionally divided up into two parts. And there's the orbital part, which is responsible for force closure. That's more on the periphery here, and then closer to the eyelids are the palpebral part, and this is responsible for blinking. The proteris muscle sits on the nasal bridge. This is responsible for drawing down your brows, and it helps you make a frown or an angry face. The frontalis muscle is on the forehead, and this helps you raise your brows and wrinkle your hair. Looking at the inner lid, if you're looking at a sagittal plane, it's pretty similar. This is the upper lid. Inner lid is pretty, or lower lid is pretty similar. So you've got the tarsal plate that we talked about, that connective tissue. Within the tarsal plate, you have the meibomian gland. The meibomian gland is a sebaceous gland, and it just secretes a lipid-rich fluid that is responsible for, partially responsible for lubricating. And then the Zeiss gland here, which is at the base of the eyelashes, which is more external. Okay, so chalazion is a non-infectious focal swelling of the eyelid, and it's due to obstruction of a sebaceous gland. So that can be either the Zeiss gland or the meibomian gland. This is the most common inflammatory lesion of the eyelid, and it's associated with various diseases. So blepharitis, high blood lipids, probably due to the fact that it gives you more cholesterol, more lipids that it cannot distribute. For hygiene, and then various skin conditions, especially rosacea, but also acne and some other skin conditions. So this typically presents as a painless swelling or a mass of the eyelid. Now initially when the chalazion develops, it can be painful. And if it gets large enough, it can be